All right. Good morning, everyone. My name is Janae Oliver, or afternoon, it's noon now. My name is Janae Oliver, and I'm with the Virginia Department of Health. Welcome to the Virginia HPV Provider Peer-to-Peer Virtual Education Series presented by the Virginia HPV Immunization Taskforce, also known as VHIT. So we have a few things to work through first, just this is our agenda. So what we'll do first is do our introductions, then go over some learning opportunities, as well as do a knowledge check related to today's speaker, and then we will hear from our wonderful speaker, and then have a post knowledge check, as well as do a Q&A session. So about VHIT, VHIT is a statewide task force that consists of stakeholders from across the state. As I said, my name is Janae Oliver, and I represent the Virginia Department of Health, and I'm a co-chair of VHIT. VHIT is also co-led by the American Cancer Society with Annika Dean, Juanita Thompson, Jan Bennett, and Regate King, and Erica Fassetti represents the Virginia Health Catalyst. And as you see here, some of our partner organizations are listed, and for this specific event, we've had the pleasure of working with some really awesome systems and programs to get this off the ground. So we really appreciate them. So VHIT, as I said, it's an assembly of stakeholders, united partners promoting and supporting HPV prevention. Our primary focus is on adolescent vaccination as an evidence-based approach to prevent HPV-related cancers. We are represented. We have 40 represented organizations, and we have 2 subcommittees at the moment, our Providers and Systems subcommittee, as well as our School Health subcommittee, and our Oral Health subcommittee is soon to come, and we are a priority subcommittee of the Cancer Action Coalition of Virginia, also known as CACV. So this peer-to-peer series has been ongoing since December of 2020. It's been a really exciting series. This is actually our last installment for the moment, but we hope to continue it soon, so we will absolutely let you know. Please do get connected with us via email. We'll give you an opportunity for that at the end to continue to engage with us. We also have our next subcommittee meetings next week, so we'd be happy to share that information with you as well to get you more engaged with VHIT and the work that we are doing. So our knowledge check. We just have some questions. Please put the answers, your answers in the chat about some of this information. So the first question is, what is the difference between PAP testing / cytology and primary HPV testing? So any ideas? We'd love to hear from you all in the chat. And if you don't know, the great thing is we will learn about the difference.
There's one thing in the chat, how often you are recommended to get this screening?
I think that's a great question. I'm going to pull up the other knowledge check questions so we can get a look at those as well. What are considerations for delivery models for self-collection of samples for HPV testing? And then lastly, how can we as researchers, clinicians, and advocates for HPV-associated cancers advocate for increasing access for cervical cancer screenings? So these are really interesting questions, and I think juicy questions that I'm excited to hear the answers to. And if you aren't able to type in the chat now, just keep these in mind, and definitely great ways to begin to get our wheels turning for this conversation to come. So without further ado, I'm going to introduce Dr. Emma Mitchell. Dr. Mitchell is a public health nurse scholar and an award-winning educator and assistant professor, and co-directs UVA Nursing's global initiatives. She studied issues that affect uptake of the HPV vaccine, the feasibility and acceptability of the HPV self-collection tests, and with colleagues has led a study on how pairing the HPV vaccine with other immunizations led to increased rates of vaccination. Dr. Mitchell's work in Nicaragua focuses on distributing HPV self-collection tests to women in Nicaragua's rural Caribbean coast, as well as training providers to recognize and treat cervical cancer. She also oversees a unique disaster preparedness program at UVA in Bluefield, and At UVA, she also teaches courses on public health nursing, local and global health disparities, and social entrepreneurship and cancer prevention in Nicaragua to both graduate and undergraduate students. Dr. Mitchell is amazing, and we love working with her. So we're really excited to hear her speak. So with that, I'm going to pass it to you, Dr. Mitchell, so you can share your slides.
Thank you so much, Janae. Thank you so much to everyone for the invitation to be here today. I'm so happy that I recognize so many of the names of our wonderful collaborators in our attendance list. So thank you everybody for being here. Please feel free to interrupt me at any time. I'll try to keep an eye on the chat and hopefully my colleagues too can help me. It's also fine to unmute at any time. I'm very happy to explain anything further or add in any details. So thank you again for that wonderful introduction. I'm going to go ahead and share my slides and there we go. Can everyone see my slides okay? The first slide should be, okay, great. Thank you so much. All right, great. So today I'm going to talk about the continuum of cervical cancer control and prevention, knowing our audience is a wonderful mixture of community partners and clinicians, as well as some researchers. I'll try to touch on relevant topics related to cancer control, cervical specifically for each of our attendees' interests. A little bit about vaccine equity, certainly a topic we hear about every day in the context of COVID vaccine equity, but also thinking about HPV vaccine equity on a global scale as one of the, maybe we could consider precedents to current vaccine equity discussions. I'm going to talk a lot about primary HPV screening and give some examples of delivery models that have been successful in other parts of the world as well as here in the United States. I'm going to talk about screening guidelines and implications, and thank you for that first question about the difference between screening intervals, particularly with Pap cytology testing and primary HPV testing. And I'll talk about considerations specific to Virginia and beyond. So here are our knowledge check questions, which you've just seen, and I'm going to touch on answers to each of these. And again, please feel free to unmute or interrupt me at any time. So I'm going to talk mostly about HPV screening in the context of secondary prevention for cervical cancer, but it's almost impossible to talk about this great goal that we in the World Health Organization and other key stakeholders around the world, this great goal that we have of eliminating cervical cancer can't really be discussed without talking about all three legs of the stool. So our first leg of the stool being primary prevention with vaccination, and then the second leg being screening and early detection, in our case today with HPV primary screening, and then the third leg being treatment and survivorship resources. So I'm going to talk mostly about that second leg, but we'll touch also on the first and third leg. So when we talk about cervical cancer control, it's really a continuum. So you can see at the bottom here, the continuum as laid out by NIH, and specifically looking at all these different columns as sort of waypoints on the way towards understanding that whole continuum of cervical cancer. We begin with knowing what the etiology is or causative factor, and of course, establishing HPV as the causative factor for 99.9% of cervical cancers was a Nobel Prize winning discovery, and certainly has had a huge impact in the last several years, several decades. So prevention, again, through primary prevention with vaccination, secondary with screening and early detection, and then tertiary with treatment for cancerous or precancerous lesions, as well as access to survivorship resources. HPV vaccination, of course, being one of our most powerful tools, right? Primary prevention, intervening before there's even been an exposure, is going to give us the best opportunity to prevent the subsequent development of not only cervical cancer, but we know increasingly other types of HPV-associated cancers as well. We get protection from that same vaccine. So interestingly, cervical cancer, we have these great tools to prevent it. HPV vaccine, such a powerful one. Screening and early detection, we're able through these complex and innovative tools to be able to identify those potential precancerous or cancerous lesions for cervical cancer early. And then we have great tools for treatment as well, treatment and follow-up. And so when we see people dying of cervical cancer, it means they're not able to access those services. So we have a real disparity there. So I always consider in my research that cervical cancer is in fact a cancer of disparities. No one should be dying of cervical cancer. The tools exist for prevention. So if we see people dying, then we have, again, an access issue. In fact, we see that 85% of the burden of cervical cancer is found in lower middle income countries or resource limited settings. In the United States, because we've had a national level cervical cancer screening program since the 1950s and 60s, we've seen a real decrease in mortality associated with cervical cancer. And now a lot of research efforts, in fact, focus on the sort of pockets of and vulnerable populations who are still experiencing high levels of incidence and prevalence of cervical cancer. The cervical cancer is one of the leading cancer killers of women globally, though not in the United States as a leading cancer killer of women. Globally, it remains so. And so it's monitored at a global level through the World Health Organization's IARC branch. And so they're what we could consider sort of the cancer epidemiology branch of the World Health Organization. And they do annual country level reports analyzing the number of cervical cancer cases. They look at, in some cases, if they're able to get data on the genotypes of HPV that are causing the most number of cancers, as well as what percentage of the eligible population is being covered by screening. So that data really helps us to answer some of those questions about access. If we're seeing a country or a community where we're seeing high levels of incidence and mortality, what infrastructure is there for people to access for those preventive services? So here we have in the blue line, and I apologize, I kind of broke this diagram into two just so it was a little bit easier to see. But here we have the Americas. So we have our hemisphere, and we have across the bottom the cases or deaths per 100,000 women. Blue lines are mortality or deaths, and the orangey lines are incidence or the number of new cases. So we can see ranked by mortality here in the Americas, we have Jamaica with the highest mortality. I've put a little bracket around two countries that I've done research in, which are Nicaragua and Honduras. And then I made a note of where the US is. And again, because of our national level cervical cancer screening programs that have been in existence for a significant period of time, we don't see as high mortality in the United States related to cervical cancer, although we still do see some incidents, as you can see here. This is the most up-to-date global data on incidence, which again is those number of new cases. We previously had global data from 2012. This paper was published in Lancet in 2020 and is 2018 data. So this is the most recent data that's available on a global scale in terms of the proportion of the population that has new cases. This is also age standardized. So we've taken into consideration the highest risk age group where we expect to see cervical cancer. And with that in mind, we can see here based on the color gradient of the country, what the incidence is. The darker the color, the higher the incidence. And so you can see there are geographically target areas where we want to be consolidating efforts. And so in my case, as I said, I've been working in Central America, particularly in these two countries, but also certainly have collaborators in South Africa and other places as well. I want to note that, as I mentioned, this data is 2018, and it's important to note that there are also a lot of efforts underway on a global scale to try to quantify the impact of COVID-19 on screening for cervical cancer as well as other types of cancer. We saw in the United States a significant nosedive in cervical cancer as well as other wellness screenings throughout the time period of the lockdown and beyond, with people having fear in accessing preventive services and really relying only on emergency services. We also have seen, as I'm sure you've discussed in some of the other peer-to-peer lunchtime talks, that we've seen a real decrease in HPV vaccination as well. And so hopeful that while we're supporting more vaccination, particularly here in Virginia with the new legislation that went into date on the 1st of July for incoming 7th grade girls and boys, hopeful that that will be able to get us back on track. I think it's a really, really powerful message. So again, this is our incidence when we look globally, and it's followed closely by mortality. So here are where we see the deaths. And again, the more the darker the shade or gradient of the country, the higher mortality we see. And it follows the pattern of decreased access leading to these disparities, because we see in the countries where there's higher incidence proportionally or comparatively similarly higher mortality. So the same access issues that are leading us to see high cases are also leading us to see high rates of death. So there are many international initiatives to try to increase access to HPV vaccination. One that I'll just touch on briefly is through Gavi, which is the Global Alliance for Vaccines and Immunizations. The countries that have green circles here are those that have national vaccination programs. The countries that have purple circles are countries that do not and that are eligible for Gavi funding. Gavi works at a national level with governments who can apply to Gavi for subsidizing vaccinations, not just HPV vaccinations, several childhood and other recommended vaccinations, but definitely also including HPV vaccination. In many countries, the vaccine that's specifically offered through Gavi or supported financially through Gavi is a bivalent vaccine. So whereas we have a nonvalent vaccine in the US right now that protects against 9 genotypes of HPV, the one that is subsidized by Gavi in many places is bivalent. And so it protects against the 2 highest risk genotypes, which are 16 and 18. I'll just really quickly mention that some countries have found creative ways to try to balance the cost of the vaccine with the benefit that it confers. So if we see that we have our non-valent vaccine, again, with those 9 genotypes, we're offering protection to people in a wide range of ages, in our case, 9 to 26, or if you're a woman, up to 45 in conversation with your healthcare provider. And if you're a male, then it's 9 to 26. So we have a wide age range and 9 genotypes we're protecting against. So we would anticipate our curve for incidence and mortality to decrease pretty steeply. Now, in comparison, Honduras, for example, I just give it as one case study, has determined that the cost effectiveness means their country rollout of HPV vaccination is to 11-year-old girls only. So whereas the curve I just mentioned would have a steep decrease, the curve of decreased incidence and mortality with only one age group and only one gender is not going to be as steeply curved. It's going to be a slower curve where we will ultimately see a decrease in incidence and mortality in Honduras as more and more girls turn 11 and are eligible for the vaccine and then continue with their lives, but it'll be a slower curve. So I just bring that up as one example. When we think about distribution of the vaccine, when we think about how many genotypes it covers, and when we think about how countries access it. So again, my main focus today, even though you can't not talk about all 3 legs of the stool, my main focus is on secondary prevention or screening and early detection. And if anyone's into Google Doodles, this is the Google Doodle of Dr. Papanikolaou, who's credited as the founder of the PAP test, which of course is where the name comes from. You can see here that he's visualizing cells that have been collected from the cervix for those precancerous or cancerous lesions at the cellular level. And so that's where the word cytology comes from. So often you might see PAP test / cytology linked together because the PAP test is what's done to collect the cells and cytology is the process to analyze it. So this is Dr. Papanikolaou. It was a few years ago that Google did the doodle. I think it was in commemoration of his birthday. So our current screening recommendations in the US are interesting. So 2012, there were recommendations made. 2018 is the most recent time they were updated. So this comes from the USPSTF, the US Preventive Services Task Force, who's a group of researchers and clinicians who are charged with weighing all of the available evidence. And so they give the evidence that's available a grade. And so you can see on the farthest right column where those grades are. The best graded evidence is that every 3 years, beginning at the ages of 21 and through the age of 29, people should receive a PAP test, PAP cytology. And then from the ages of 30 to 65, there are 3 choices. One is to continue with a PAP test or cytology every 3 years. One is to add into the PAP test in combination with the PAP test, an HPV test. And this would extend then the screening interval to 5 years. And then the third option is to have only an HPV test, which would be also a 5-year interval. So thank you to the to Noelle, who asked the question earlier about the differences in the screening intervals. It is complex. It certainly is. And there are ramifications clinically and in terms of the research that we track. So I'll just touch on those briefly. We did a quick study in Far Southwest, and we did it beyond Far Southwest. We also looked at neighboring neighboring towns and cities where people who live in Southwest Virginia might access care. And we interviewed 50 practices who provide Pap testing, and found out that because of those changes in guidelines, there was some confusion about what the recommended screening intervals were. And if that's true on the part of our clinicians, it's certainly going to be true on the part of our patients. I think that for a lot of people, it's important to teach the difference between what a Pap test is and what an HPV test is. In this country, they're offered together. In some other countries, they're offered together. But now the World Health Organization is really encouraging that countries, especially those low and middle income countries, move towards HPV testing only. But if we don't understand the difference as providers, or if we don't share that difference or explain that difference to our patients, it's going to be a slow change, I think, in our context. In the introduction, Janae mentioned that VHIT is part of CACV, the Coalition Against Cancer for Virginia, who works on, in partnership with many different partners, VDH and American Cancer Society, among them, the Virginia Cancer Plan. So the most recent Virginia Cancer Plan includes one of their goals. They have a goal about HPV vaccination as well. And then one of their other goals, goal 6, is to increase high quality cancer screening and early detection rates for Virginians. So this is obviously very exciting for me. One of the objectives is to increase the percentage of women aged 21 to 65 who have had a Pap smear in the last 3 years. Now, the highlight that's green there is because I did a word search before I did this screen grab of this image here. So the apologies for the green, that's left over from my word search. But you'll notice that the indicator that's tracked, or the objective that's tracked, is really only about Pap testing and cytology. And that's because a lot of their metrics, their baseline metrics and their targets, are based on what you can see here, BRFIS data. So BRFIS is the Behavioral Risk Factor Surveillance System. It's the largest phone-based survey that's done in the US. It's done annually. It's overseen by the CDC, but each state does a core set of questions about health behaviors, and then they can also sometimes opt in and opt out of other modules. So in 2014 and 2016, for example, some states opted into asking modules about HPV vaccination and some states opted out. So all this is to say, BRFIS collects the data as only Pap testing. And part of the reason is, back to what I was just mentioning, not a lot of people necessarily know the difference between a Pap test and an HPV primary screen. So coming from that place or understanding, then BRFIS asks about cervical screening behavior specific to Pap testing. That, therefore, is then the only data that we have to base the plan off of, et cetera. You can see there's a ripple effect there. So I think it's really important for us as researchers and clinicians and community partners to help spread awareness about what HPV testing is and why it's important to know the difference. So here's just a quick summary again of the 2018 USPSTF guidelines. Down in the bottom left, you can see I have 2 pictures of the Pap test cytology process, where again, a provider uses a speculum, collects cervical cells, and then looks at them under a microscope for those precancerous or cancerous changes. Whereas an HPV test, we're actually looking for DNA from the virus itself in cells. So cytology shows you if there's precancerous or cancerous changes in the cells. HPV testing shows the presence of the virus, which we know puts you at risk for cancer. So it's a different type of screening. I wanted to just quickly add in a third type that's been researched extensively and not found to be as precise as either Pap testing or HPV testing. But because, as I mentioned, about 85% of the burden of disease is in low and middle income countries, there is an inexpensive way to search for potentially cancerous lesions with the cervix, which is called VIA, or visual inspection with acetic acid. And here what happens is table vinegar is diluted and applied to the cervix, and it actually does something called aceto-white changes. This means that the cervical cells actually turn white if there's a precancerous or cancerous lesion, and providers can then try to immediately intervene. As I said, it's not as sensitive and specific as Pap testing or HPV testing, so those are really what we want to emphasize, but it is a third option that's used sometime in other places, so you might hear about that. So here on the left, we have Pap testing. We're looking at those cells. On the right, we have, or on the right of the first column, we have HPV testing, where we're looking for the DNA of the actual presence of the virus itself. So when we do HPV primary testing, because we're looking for the virus, it's actually a different process, although it can be done at the exact same time as a Pap test. So a provider would use a brush, and you see here I've included, and I apologize, they're a little bit blurry, but I've included a couple different styles of brushes. So if you're a provider or if you've had a Pap test, you may notice there's this one that looks kind of like a Christmas tree. We have this one that has this sort of pointy shape. And so providers sometimes have different preferences over what type of brush they want to use to collect the sample. But a lot of research has gone into, from biomedical engineers to epidemiologists and pathologists, a lot of research has gone into what is the best design of a brush that we can use to collect this type of data, to collect this kind of sample. The two bottles are also sometimes part of the equation. They have preservation fluid, which then the sample goes into, travels to the lab, and is processed to get the result. Now, when we get to the lab, that's an interesting consideration. There are a lot of HPV tests that are out there and being used, but it's really important to know, and certainly clinicians and providers are acutely aware of this, but it's really important to know which of those tests are FDA approved or approved by the World Health Organization. So I'll just draw your attention to a couple here. The COBAS test, which is manufactured by Roche, which is the company, is FDA approved. This number indicates sort of the level of evidence that has been published about it. And that's within 3 years and then within 5 years. And that's the negative predictive value. When we try to understand how good a test is, we want to know how many false positives and how many false negatives there are. But we also want to know how good is the test at truly discerning between the true positives and the true negatives. And so this is just an indication that the COBAS test in particular has a high level of publication about negative predictive value of the test within 3 and within 5 years. And in fact, many of your practices, if you're a provider, probably use this test. This is what we use as the standard here at UVA. A test that I used was similar to this, Hybrid Capture 2, and manufactured by QIAGEN. I used this in Nicaragua with also HPV primary screening, and that has continued to develop evidence. So the purpose of this slide is really just to say that it is important to understand what is approved by the FDA and how we can use that clinically. And I'll come back to FDA approval in just a moment. So once we have an FDA approved test, we know how we're going to collect the sample. We know that the test is FDA approved and is going to tell us the presence of high-risk genotypes of the virus. Then we can make clinical decisions. So our clinical decision making can be supported by guides. And so this publication is from ASCCP, which is one of the leading clinical organizations, professional organizations in the States that helps with things like treatment algorithms. So if you get X result with the HPV test, how does that then inform your clinical decision making? And you can see one of many algorithms here. They have a really, really user-friendly app as well, where you can type in demographics of your patient or different considerations, and it can help you to determine at which point in your screening and triage of this patient or research participant, which direction you want to go in for their further care. Now, we went over that a clinician is necessary to collect those cervical cells for a Pap test or for the cytology process. That is how it's FDA approved, is that a clinician collects it. Currently in the United States, it is also only FDA approved for primary cervical screening. In other words, for clinical information that you would base treatment on for a clinician to collect an HPV test. However, there's been a lot of research around the world, including here in the US, about whether women can collect their own sample for HPV testing. So remember that the lab test that we use is FDA approved to tell someone if they have the presence or absence of those high-risk genotypes, but it's only FDA research approved for a woman to collect her own sample. The research shows, though, that women and clinicians can collect comparable samples. The research also shows that women and clinicians can collect comparable samples in the clinic, or that women can collect sufficient samples in other locations, including at home. So that's what opens up the really exciting part of HPV primary screening is that if a woman can collect her own sample, we've changed the game in terms of the barriers she might have been experiencing in accessing existing services. So again, in the literature, and this is global literature, research has been done in China, in Western Europe, Australia, Rwanda, the UK. There's a big trial in London that was disrupted from COVID, but I believe is back on track. Canada, other parts in the US. So there's a global body of research and evidence supporting not only the comparable collection for samples of a woman and the provider, and as I said, in the clinic or at home, but also that we are seeing a woman being able to collect her own sample is reaching vulnerable populations who weren't otherwise accessing services. In other words, it takes down some of the barriers people have to accessing services. Now, it doesn't replace a clinician visit. It doesn't replace a wellness, an annual wellness visit. But research is increasingly showing that for women who weren't otherwise accessing those services, being able to collect their own sample is proving to be a connector to more sustainable primary care. It's showing to be a cue to action. So doing the self-test, knowing what your result is, knowing you need to follow up is actually showing that it's connecting people back to care. So this is an example from Sweden of instructions that were sent through a mail-based kit. Women who were found to be not engaging with existing cervical screening were mailed this kit. You can see the barcode, so it was very much tailored to each individual person. They were sent this brush. You can see the instructions for how to open the brush, how to insert it and collect your sample, and then how to return your sample through the mail, so through a prepaid envelope. So a very easy delivery model there. If we know that being able to collect your own sample decreases barriers, then, and we also know that the HPV test has good sensitivity and specificity, or that good negative predictive value, then we have a real tool, a really innovative tool on our hands. I think, and where my nursing research comes into play here, is in acknowledging that even though it's a great and innovative tool, it's not a one-size-fits-all tool. So I want to touch on a couple different delivery models of the same or very similar technology that have been tailored to specific areas. So this is a model that worked really well in Sweden. So in Sweden, receiving something in the mail with instructions, collecting your own sample, mailing it back, that was a delivery model that worked very well in this geographic area within Sweden. It also worked very well in North Carolina. So one of my colleagues, whose name is Janae Smith, she's at UNC, has done extensive research all over the world, but including in North Carolina, focused on trying to reach really vulnerable people with mailed kits. And so she also worked with clinics to find participants who were not engaging with cervical screening. In other words, maybe they come in for their flu shot, or maybe they come in for a sick visit, but they're not up to date with cervical screening recommendations. So they received a kit in the mail, they mailed it back and received their result, and then were navigated to follow up in a clinic. And so that's one model with the mail. A different model was used in Miami, Florida, which was one of the, chronologically at least, one of the first places geographically within the US that really started with self-collection research. The first author here, Erin Kobitz, is a real leader in HPV self-collection and worked in Little Haiti and Little Havana in Miami to work extensively with community health workers. And so her delivery model of very similar, if not the same technology, was really in partnership with community health workers who went door to door and accessed women in community meetings and things like that, with very much community-based recruitment. And was able to really successfully deploy the technology and get more women ultimately connected with primary care through that delivery model. So that delivery model is a little bit more similar to one that we worked with partners in far Southwest Virginia to work on. It was just published last year, but the main data was collected in 2016 and 2017. This was our geographic area of target. It's really important to note that we worked with long-term partners through our community advisory board. UVA has a Cancer Center Without Walls, which is a strong and long-lasting collaboration with stakeholders in planning districts 1, 2, and 3. And I'm so happy to see familiar names of people who are here today who are long-term members with that. And so I, as a researcher, really was able to partner with this community advisory board to get feedback as I went, to get feedback along the way, and not design a study or impose a study that really wasn't regionally relevant. And so I really benefited from that collaboration and informing each step of the process. And one partner in particular that really made our study happen was Mountain Empire Older Citizens, based in Big Stone Gap, but with a catchment area across planning districts 1 and 2. Joint Area Board of Aging, Joint Area Board of Transit, have a PACE center, and those are just 3 of many extensive programs that MEOC has. And one I was able to partner with was working with home health aides who we trained as lay navigators. We began by finding out from them what they anticipated regionally relevant barriers might be to accessing existing services, which services people felt more comfortable accessing, and how best to recruit and approach people to be part of our study. We did an environmental scan, which we used then to help be able to navigate people after they got their result back to primary care. And then we actually implemented HPV self-collection in 2016, 2017. So we trained 64 lay navigators, 35 of which really took on the mantle of the study. They worked to recruit women who met our eligibility criteria. So we had 77 kits total that we distributed to those 35 lay navigators. 59 of them were mailed back to us at UVA. 42 of them were 100% completed. And we looked for women who were 30 to 64 who had not had either PAP testing in the prior 3 years or HPV testing in the prior 5 years. We found a 16.6% high-risk HPV positivity rate, which is a little higher than we would have expected and might speak to some of the unique risk factors in this geographic area. But what was really interesting too is almost a quarter of our sample didn't have a medical home. So they didn't have a sustained primary healthcare provider that they visited. That being said, many of our participants had seen a healthcare provider in the past year. So again, for something like a flu shot or a sick visit, and they were not told that they were due for cervical screening. And so that is an opportunity that we might be able to partner with clinicians and providers in order to try to promote some kind of, flagging a reminder system for when people are due. So in this area, lay navigators proved to be a pretty great delivery model for this technology, particularly since we accessed so many people who didn't have sustained primary care. Most of the studies I just mentioned to you start with a clinic, find from that clinic which patients are under-screened. In our case, because we didn't start with a clinic, we started at the community level, we were able to identify even more vulnerable folks who didn't have a medical home. So I mentioned FDA approval is there for the actual test itself for HPV testing. It is only FDA approved for research purposes for a woman to collect their own sample. So if you're enrolled in a trial, in a study, then it is FDA approved for you to collect your own sample, but as a research result. And so hopefully we can move the needle on that within the US. Many countries around the world already have self-collected HPV as their primary screening modality. And so I'm hopeful that we can change that in the US as well. We as advocates can really help try to dispel some confusion and misinformation about the USPSTF guidelines and the differences between those PAP tests and HPV primary testing. And then again, this technology is really not designed to take the place of those wellness visits and those connections with providers. It's really aiming to try to help women who aren't otherwise accessing those services to connect to more sustained primary care. And I think all of us here, as advocates and advocates for prevention and especially for this so preventable disease, I think all can get behind that idea. So just to finish really quickly with how this relates to what the rest of the world is doing with cervical cancer, the World Health Organization launched last summer, despite lockdown and despite the pandemic, launched a very anticipated campaign to eliminate cervical cancer globally. The ambitious plan is set for 100 years from now to have cervical cancer be eliminated. And there are a set number of goals that are supposed to be reached in the next 10 years. In order to, by 2035, in order to have us be on track for that 100-year elimination of cervical cancer. Now, some countries are already on their way, right? Australia has clinically eradicated genital warts. And so not cervical cancer, but also a human papillomavirus lesion. So that's really exciting. Australia and Rwanda, because of their school-based HPV vaccination rates, are also on track to be some of the first countries to eliminate cervical cancer in a much shorter time span than 100 years. But in order to reach that, to try to get our global community closer to that goal by 2035, to be on track for that 100-year elimination strategy, the WHO recommends that 90% of girls be fully vaccinated against HPV by 15 years of age. 70% of women are screened with a high performance test by 35, and ideally a second lifetime screen by 45 years of age. What's interesting is when you see the phrase high performance, the World Health Organization is specifically talking about HPV testing. They want to see HPV testing be developed to be more financially viable in low resource settings, as it really is seen as one of the leading ways to screen. And then our third leg of the stool, again, our third goal is for 90% of women identified with cervical disease to receive treatment for precancerous lesions or invasive cancer. And then in some documents from the WHO with the same strategy, they also add in their survivorship resources. So I've included here a couple links about when the sort of press releases and when the information came out about the WHO launching this elimination strategy. But again, you know, this quote has been around for a while in anticipation of launching the strategy. We can eliminate cervical cancer as a public health problem through intensified vaccination against HPV, screening, and treatment. So again, here are our knowledge check questions. And if you have any other questions or if I can clarify anything further, I'm very happy to. But we talked today about the difference between Pap testing, cytology, and primary HPV testing, that the tests look for two different things. We talked about considerations for delivery models of self-collection, some male-based or you know, male-based models might work. Having an individual like a community health worker or early navigator might work depending on where you are. But I think, again, this is where some of that real community-based research, and in my case, nursing research, comes into play, because the technology is wonderful, but it's not a one-size-fits-all. We're only going to have successful engagement with women who are underscreened and therefore already vulnerable if we have a culturally acceptable and regionally appropriate delivery model. So I think those nuances are really important. And then we as researchers, clinicians, and advocates for HPV-associated cancers can advocate for increasing access for cervical cancer screening through education about the difference between testing modalities, through trying to use this technology to connect people to more sustained primary care, and through, you know, working in partnership with providers to try to find more opportunities for reminders for things like being up to date with cervical screening. So thank you so much. I want to thank VHIT and CACV again for hosting this wonderful series. I think it's so wonderful to see all the different facets of research and clinical practice associated with HPV. I think I'm sure you'll have enough topics for several more years. But if anybody has any questions, I put my email address here. And then if you happen to be a Twitter user, I only ever tweet about climate change and cervical cancer. So if you follow me, I promise to share with you some interesting information about cervical cancer on global and local levels. So thank you so much.
Dr. Mitchell, we do have a question, just looking at the data that we do have available.
Yeah.
Is there a specific area in the state of Virginia where cervical cancer is the highest and where we should focus, you know, the most initiatives and education?
Sure. So there are hotspots when we do an analysis similar to the world maps I showed you with the color gradient by country. When we do an analysis looking at different counties and geographic areas in Virginia, we see similarly some of those hotspots. Far Southwest Virginia, there's an area in South Side, and then at the Eastern Shore, there's also an area where we see higher incidence and in some cases higher mortality than in other parts of the state. Interestingly, there's an analysis that was done to compare within Ohio, Virginia, Kentucky, and maybe North Carolina. There was an analysis done to compare counties that were considered Appalachian or within the Appalachian boundaries and non-Appalachian counties. And when you look at all four of those states, Virginia was ranked number 2 in the difference between Appalachian counties and non-Appalachian counties. In other words, our Appalachian counties are the second most vulnerable compared to those 4 states, if that makes sense. And so I'm actually working on a project with 3 of those 4 states, Ohio, West Virginia, Virginia, and Kentucky. I'm one of our cancer center members who's working on 3 different projects combined to try to address cervical cancer in Appalachian, Virginia, Ohio, West Virginia, and Appalachian, Kentucky. And we're looking at, number 1, helping to provide tobacco cessation to people who are tobacco users, because we know that there's an interaction between tobacco use and the immune system, and the way it suppresses the immune system puts people at risk for recurrent high-risk HPV infections. And then the second project is to try to increase HPV vaccination in those counties. And then the third project is my project, which is an at-home self-collection project. So women who are identified from the clinic who are under-screened or are due to be screened will receive a kit in the mail and mail it back to us and then be navigated for follow-up care.
Awesome, thank you.
Yeah.
I don't see anything else in the chat, but would certainly encourage you guys to come off mute, ask questions. And then of course, Dr. Mitchell, thank you for offering your email there so we can connect later if we have other questions. Okay, there's another comment just sent. As someone who works in outreach and education, what strategy would you recommend for us to use to encourage community members to get Pap tests? And does the research have one advised method?
That's a great question. I don't know that there's one advised method, because I think that sometimes the barriers are unique. So I think one of the things I've seen in the literature a little bit and would encourage people to do is incorporate some kind of data gathering within your clinic or your practice to find out from people what those barriers are, and concurrently try to build in some kind of reminder system. So whether it's within your EHR, there's an ability to flag people who are underscreened. If you have someone who comes in for, like I gave the example of a flu shot or some kind of sick visit, it might be an opportunity to say, hey, you're here anyway. Some of those barriers keeping you from getting screened are already out of the way, because the time, transportation, et cetera, you're already here. So let's go ahead and encourage your screening. So I guess those kind of 2 things. 1 is find out from people what the unique barriers might be that they're experiencing. And 2, see if there's an opportunistic way to promote screening when people are coming in for other things.
Yeah, that's great. Thank you. And we, often talk about, outside the screenings, but the prevention side with vaccinations, and pediatricians taught, wrapping that any opportunity that patient is there in their office, a sick visit or whatever, that it makes sense and it's appropriate to offer and get the vaccination done. So
absolutely. And then further too, in terms of what the research shows, that provider recommendation is one of the biggest considerations parents have in terms of deciding to get the vaccine or not. A provider's strong recommendation goes a lot further than asking parents if they want the vaccine, and further sandwiching that vaccine along with other vaccines has been found to really help parents uptake and comfort with getting the vaccine. I obviously am a strong proponent of HPV vaccine, and so never like to encourage people to be given a choice related to it. It's such a powerful tool. In more and more that we're learning, it protects against other types of cancer too. I hope that we can encourage anyone with hesitancy to see the benefits, because they're vast.
Absolutely. Thank you, Dr. Mitchell.
Thank you.
Get another second here. If anybody wants to send in a message or come off mute, now's the time.
This is Diane. With the people hearing side effects from the COVID vaccine, and do you think they'll question about side effects for the HPV?
That's a great question, Diane. Thank you so much for being here too. And I'm worried that is going to happen, right? We saw anti-vax, theories, however erroneous and however not founded in science, related to side effects of HPV vaccine before COVID. And I do have the same worry, Diane, that people seeing more and more side effects from COVID vaccine, it having a resurgence of fuel for the anti-vax fire. Second only probably to the COVID vaccine, the HPV vaccine is one of the most researched vaccines we've had. And so it has never been found to have more side effects than any other vaccine, meaning a tiny, tiny percentage of people have had some kind of side effect, but we can't attribute it only to the vaccine. There might be confounding factors, et cetera, but there's no reason to think that the HPV vaccine isn't safe. In fact, there are fewer side effects than COVID vaccine. But I think that a big part of our advocacy and prevention work in this context, just as you said, Diane, is to dispel those myths and to try to dispel the difference. They're different vaccines that work different ways. So thank you for bringing that up. And I think we just have to keep working towards that.
Thanks.
Thank you.
Okay. Janae, do you have some other closing slides that we can pop up, or just? Awesome. Thank you. As you can see here, and Janae mentioned that we have some VHIT subcommittee calls coming up. We can send that date out in the post-event email that we send, but we just thank everybody for participating in the last several months of these sessions that we've had, and we super appreciate our providers coming to us and providing, as Dr. Mitchell mentioned, just such a vast and variety of conversations around HPV vaccinations and cervical cancer, and we just appreciate the providers' support and participation in this. And we do have the VHIT email address listed there in the event that you guys wanted to reach out. There's an opportunity to join subcommittees and be engaged with CACV as well as the Virginia HPV Immunization Taskforce. So please join us if you have not already joined us before, and we'd love to have support moving forward and just any opportunity to make the greatest impact against cancer here in the state of Virginia. Thank you all.